Hello and welcome to Talking Points. I'm Dave Kelly, Director of Advanced Media Production at Cal State Long Beach. Today we'll be talking about global health concerns, including communicable diseases, viral superbugs, and living conditions in general. My guest today is Dr. Kevin Malotte. Dr. Malotte is a Professor Emeritus of Health Science. Welcome, Kevin, and thank you for joining us on Talking Points.
Thanks for having me.
Let's start the conversation by talking about conditions that cause health concerns to become exacerbated, especially in those parts of the world where we see a lot of poverty, unstable governments, and civil wars. Now, we can understand why poverty is one of the main drivers of illness and disease and the spread of disease, but if we sort of peel back the layers of the onion, what are those major factors involved with poverty that seem to make it inextricable with the spread of disease?
Okay. There are a number of things that are related to income and poverty that affect the environment in which people live, the exposures that they get. So things like living conditions. If you live in a home that's not very well constructed, you're exposed to more of the elements, you're more likely to be exposed to insects, for example. If you don't have enough money to purchase adequate food, your general health is not so good. Things, if you have protein energy malnutrition, which is the most common type of malnutrition where people are not getting enough energy, you're susceptible to all kinds of other illnesses. We know that for up to 6.5 million children a year die from under the age of 5, and most of those are preventable, and a lot of those are related to poverty. So it's exposures, it's the conditions in which people live, it's the inability to get treatment when it's needed, the inability to get preventive interventions when they're needed, and it's poverty both of the individual, but it's also poverty of the country. So countries that are poor are less able to provide that for their residents as well.
So those countries don't have the kind of stability that's necessary to maintain a healthy population for a variety of reasons, as you've mentioned.
Right. So it could be stability, lack of stability, and so we know that that complex humanitarian emergencies where we've got either some natural disaster or civil disturbances or civil wars contribute to the lack of infrastructure for that kind of health infrastructure. But it doesn't need to be a disturbance. It can just be that there's not the funds to have developed the infrastructure that's necessary.
Just a general lack of resources, it sounds like. Let's talk about a specific example of where this is definitely the case. If we talk about malaria, the World Health Organization calls malaria one of the most significant health challenges in the world today. And about 90% of the cases occur in sub-Saharan Africa, in countries like Nigeria, Tanzania, the Republic of the Congo, Uganda, etc. And one of the problems is that the mosquitoes, it's a vector-based disease, and the vectors are the mosquitoes. There aren't enough resources, apparently, to prevent this spread. Why is that the case?
Well, there's some very actually inexpensive things that could be done to prevent it. So we know that bed nets, for example, probably could prevent approximately 90% of cases of malaria because the mosquito that spreads the disease is a night feeder and comes out at night, usually lives in the thatch of people's homes, comes out at night and bites at night. And so if someone's in an insecticide impregnated net, they're less likely to get bit. And those cost about $5. But that's outside the ability to pay for many people and for many governments. When people's incomes are less than $500 a year, $5 is a significant amount of money, and for the government that's the case as well. So there's things like bed nets. In the U.S., we've done a lot of work in terms of getting rid of the conditions in which mosquitoes can live. So we make sure that we mitigate, we get rid of water, standing water, we spray when needed, we monitor to make sure that the mosquitoes are not active, and those are things, again, that are outside the ability of many of these governments to pay for. So there's
So it's a matter of developing the kinds of resources necessary within those countries to be able to provide the basic care, the insecticidal long-term nets that you're talking about, and also, I guess, the eradication via spraying, but also once those individuals become infected with I guess it's the Plasmodium parasite that comes from the Anopheles mosquito that does the biting, if they don't get treatment, those levels of parasite remain high in the bloodstream, and so when a so-called clean mosquito comes and bites an infected person, that person actually becomes part of the vector.
Right.
Because then that mosquito leaves, goes to the next person, bites that person, the second person is now infected.
Right.
So we become part of the chain if we don't intervene with proper pharmaceutical treatment.
Right, and pharmaceuticals are much better than they used to be, but the Plasmodium has also developed some resistance to the first line. The cheap medicines are not as effective as they used to be. So when you buy the cheap ones, they may not work as well, and those may be the only ones that people can afford, and that's the only ones that the government can afford to provide. And in most of the countries where we're talking about high levels of poverty, we also don't have the health insurance systems, and so most of the expenses are out of pocket. People are paying for this themselves. They may get the medical care, but they won't get the medications provided, so they'll have to pay for that themselves. And again, things that are more than a dollar are going to just not be possible for people to purchase. And a lot of things, actually, in many countries also are, a lot of the medications turn out to be counterfeit. So they try to buy the cheaper ones because they think that they can afford them, but they're not really doing them any good.
So unfortunately, that's sort of the double whammy. You don't get the treatment and you lose the money you spend on it to begin with. Right. Well, just to wrap up with malaria, according to the World Health Organization estimates, about 200 million people a year are going to be infected with the malaria parasite. But of those 200 million, about 600,000 or so are going to die, and many of them are children under the age of 5. Is this preventable, as you've described?
Yes, there's really no need for children to die from malaria. If the known preventive techniques were used, we would cut that dramatically, and it has been cut fairly dramatically. In the last 20 years, the deaths from malaria have gone down by about half, but there's still too many children dying. And part of, it's not just the children that are dying either, it's that the malaria adds to poverty in countries, because people, the typical adult who's infected with malaria will have up to 5 exacerbations a year, and when they're sick, they're not able to work, they're not able to go to school if they're in school, and that then contributes to the lack of income, and this cycle of poverty and illness keeps going.
And so there's a reduction in productivity on a national scale as well.
Right.
Let's transition to another disease, Ebola, which was in the news in the fall of 2014. There was a fairly major outbreak on the west coast of Africa, pretty much confined to the 3 countries of Liberia, Sierra Leone, and Guinea. We know that about 24,000 people were affected or infected with the Ebola virus. Of those, about 10,000 actually did pass away. But the world media, it got the attention of the world media. And we heard about it for a couple of months here in the United States. And now it's ebbed substantially. We're not hearing much about it anymore. First of all, what do we know about the Ebola virus, and can it be contained, and how can it be contained?
Okay, Ebola is a virus that's not super easily transmitted. It's obviously, if you have personal contact with someone, and especially if they're in the late stages of Ebola where they're putting out a lot of the virus, it's much easier to get then. But it's not something like the flu where it goes into droplets and goes into the air and everybody in the room would be exposed to it. So we know that it can be contained. The correct practices can contain it. The reason I think that it got so much publicity was that you don't know exactly how many people might get exposed, and it can get out of hand, and it came close to getting out of hand. It got into a major city for the first time in Monrovia, Liberia. So I think that's partly why the scare. I think in the U.S. the fear was unfounded. And there may still be a case or two that gets to the U.S. from Africa or West Africa at some point, but we have pretty good systems of containing it, and it is containable.
What does this say about international travel? And what does it say about the process of quarantine in general? Quarantine does work, it can be effective. And what about international travel? Maybe another good example is the SARS epidemic that we saw in 2003. Maybe you could compare Ebola with SARS. How are they similar? How are they much different?
Okay. SARS was a disease that was transmittable through the air, and so it was more easily acquired.
Let me just interrupt for a second. It was called SARS because that stands for Severe Acute Respiratory Syndrome.
Correct.
Which means it's a respiratory thing and you can get it from the droplets.
Exactly. And a lot of the people who were affected actually turned out to be medical people. So, and because they were exposed to people who were very sick from it. And again, when you get very sick, you're putting out a lot more of the virus. I don't remember where we were going with this.
No, we were talking about the similarities between Ebola and SARS. You're mentioning that there are different kinds of viruses. One is much easier to catch, SARS, because of the nature of how it is, I guess, captured in the air through the little aerosol droplets and so on. Ebola is not quite like that. It's harder to catch Ebola.
Exactly.
So quarantine with SARS is definitely something that you have to use in order to contain it.
Yeah, people need to be, yes, exactly. The way you would want to do that is if you, there's a term we use in public health, it's called surveillance. It's not like the camera's up watching over you, but it's keeping track of who gets diseases, and when there's a disease that we don't typically see, then investigating what's going on and isolating that person who's infected so that they don't infect other people. And that's really what we're talking about when we're talking about quarantine.
We have just about 30 seconds left before we go to the break, but world travel, you have some students. When you have students that go on missions abroad in 30 seconds or less, what kind of advice do you give them?
Take all the immunizations that are recommended, take your antimalarial drugs, protect yourself from mosquitoes, and worry about travel. Worry about the transportation more than getting some of these kind of exotic illnesses. You're much more likely to die from a traffic accident when you're traveling overseas than you are from getting Ebola or some of these other diseases that are not very, very common, actually.
Okay, with that, we'll go to the break and stay with us. When we come back, we'll continue this discussion about world health concerns. Stay with us.
Do you have a talent for making an impression on people, convincing them of your ideas? Can you think of ways to sell doggy umbrellas? Or perhaps baby outfits with floor mops on the hands and feet so that when they're crawling on the floor, they're actually cleaning it? Or LED slippers with lights in the front for those dark nights? You can become a part of this exciting field with a degree from Cal State Long Beach.
Welcome back to Talking Points. I'm Dave Kelly. My guest today is Dr. Kevin Malotte, and we're talking about worldwide health concerns. And Kevin, before we went to the break, we were talking about travel and quarantine and things of that nature. I'd like to transition now to talking about the HIV virus. And the HIV virus is another one that's actually pretty hard to catch. I mean, it's not something you're going to get if someone happens to sneeze in the vicinity. It's not that kind of disease. You've done a lot of work, a lot of research on HIV, and where are we in terms of research and prevention and the possibility of a cure? Is there any chance there will be a cure or a vaccination in the foreseeable future?
I'm not sure that we'll have a cure or a vaccine in maybe as long as I'm alive, but we will, I think, make progress, and we have made progress, and I think the goal now, and it's something that you didn't used to hear. 10 years ago, you didn't hear it. But now the goal really is an AIDS-free generation. So within 30 or so years, the hope is that there will be much, much less HIV. I think that there's certain things we know work now that we didn't have in our arsenal before that are going to help. The vaccine is a little bit more in the future, I think. We've been working on vaccines for a long time, and I think we're still a ways from having a vaccine that's effective. We've had a lot of false starts. I was involved in a vaccine trial 20 years ago that didn't work. I don't think we're really much further along now than we were then. So, but there is hope, and there is reason for optimism that we're going to have better results in the next few years.
Okay, well, the virus was identified probably about 34 years ago or something along those lines, 1980, 81, back in that era. And in that course of time, about 79 million people worldwide have been infected by the disease. I think roughly 39 million, or 39 million, or almost half of those have died. Right. Here in the United States and in the Western world and in countries where they have access to the proper pharmaceutical treatment, it has become more or less a long-term manageable disease. But there are still concerns that people may develop a resistance to the pharmaceutical intervention, and there are also concerns that people may become complacent if they think, well, there's a drug treatment, there's a drug regimen, if I do catch it, I'll still be okay. That's not the way people should be thinking. Prevention is always the best way to go.
Prevention is the best way to go. Even if you are able to take the medications, there are side effects to the medications, there is the risk of resistance, there is the hassle of taking them, there's the cost of taking them. So it's obviously much better not to get infected. So that we need to think in terms of prevention. And we know that there are a lot of things that can be done to prevent acquisition. There are not very many behaviors that will transmit HIV. As you said, you're not going to get it from sitting next to somebody on an airplane. You're going to have intimate contact of some sort with that person. And so if you're able to engage in the behaviors that will protect you, you can prevent yourself from getting infected, and that's really where we should go. One of the things that's caused optimism in the last few years is that we know that treatment helps the individual who is infected and prevents them from progressing the way they used to in the 80s and 90s when it was really, it was a disease that was decimating many communities. So treatment we know works for the people that are infected, but it also is being used now as called treatment as prevention. So if you were able to have someone take their medication the way they're supposed to, it lowers what's called their viral load, which is how much virus they have in their system. And when they have a lower viral load, they're less likely then to transmit to someone else. So if you can treat many people in a community who are infected, it will make them much less likely to transmit to other people in the community and lower, we call it lowering community viral load, and lowering then the community risk of getting infected.
Okay, let's transition now to talking about vaccinations in general. Okay. In this country, in the United States, something like 10% of parents are now, or have been in the past few years, refusing to vaccinate their children. And this is based on basically 3 different perceptions that are out there, or misperceptions, and I'll have you address each one of them. The first one is there was a theory, a rumor that was going around several years ago about vaccinations in children linking to autism. So in other words, if you vaccinated your child, there's a good chance they might develop autism as a result. What do we know about that?
Well, the major impetus for that idea was a paper that was written that was published in The Lancet a number of years ago, and it linked immunizations with autism. And unfortunately, the person who wrote the paper actually fabricated his data, and not only were they misinterpreted, they were out and out fabricated. And the journal retracted that paper when that was discovered. And there have been a number of other studies that have been done since then that have shown that there is no link between autism and vaccinations. Part of the problem is that people, their first symptoms of autism are during the same times when they're getting vaccines. When they're children, young, under 5, they're starting to get those. And so people temporally they're related to each other, but they're not related. There's very, very strong evidence they're not related in fact.
So we can reassure the public that that was a false report and that it has not been verified and there's no information to link vaccination with
not only has it not
autism.
been verified, it's been debunked, and there's been lots of other research that has shown that that's not the case.
Okay, so we'll put that one
I
aside.
think that one can be put aside.
The second one is that people are concerned, they've heard in the past or read somewhere that the vaccinations themselves, the vaccines, can sometimes be contaminated with chemical elements, and one of those elements is mercury. Are there contaminants in the vaccinations these days?
I think not. There may have been manufacturing issues in the past. We have a pretty good handle on what things are going into these vaccines now, and I would not worry about that at all.
Okay, and then the third one, I think I said there'd be three,
Right.
but the third one is this idea that there's a live virus in that inoculation or in that vaccination I'm about to have, and I'm afraid I'm going to catch the disease from that live virus, which I wouldn't catch otherwise.
Okay.
What about that one?
Well, most of the vaccines are not live viruses; they're killed viruses. But some are live. They're live. They're called attenuated, so they're made so that they're not virulent anymore. They're not going to cause illness. And you hear that because people get a vaccine and then they get sick. And flu vaccine, I've heard many people say, I'm not going to get the flu vaccine because last time I got it, I got the flu. Well, it probably wasn't that they got the flu from the vaccine. They got the flu because either the vaccine was not effective against a particular strain of flu that they were exposed to, or they got a less severe case of the flu, or it wasn't really even the flu at all. It was some other illness that, a cold or something that they assumed was the flu. I hear that all the time. And but there is, I don't want to say that vaccines are totally safe 100%. Right, exactly. Yeah. So there is some small risk associated with any vaccine or any medicine that you take. There is some risk associated with that. And so you hear those stories, but and in the U.S., we've become kind of desensitized to how serious some of these illnesses are. But measles, for example, still kills hundreds of thousands of children a year around the world. We have very few in the U.S. because we've done a good job of immunizing people.
Although it's coming back now because of what I mentioned a few minutes ago, and that is parents are deciding not to vaccinate their children because of those three worries that I mentioned. And so as a result, we've now seen the measles epidemic grow to something like 17 states the last time I read the statistics. So we had measles basically gone from the United States, and now it's making a comeback. Why is this a potential problem?
Well, it's a potential problem if that kind of sense from different communities that they shouldn't vaccinate their children takes hold. Then if we get below a certain level of vaccination, we lose what's called herd immunity. And herd immunity protects people who can't be immunized. So children under the age of 6 months, for example, they shouldn't be having a measles shot. And people who may have other illnesses that would make it difficult for them, or they shouldn't get the vaccine, there are medical reasons they shouldn't get a vaccine. In those cases, those people are protected because everybody else around them is vaccinated. If we lower that rate of vaccination, then we no longer have that herd immunity, and then babies, other people that have other immune compromised situations are going to be exposed to some of these illnesses.
Okay, as far as other issues that are not necessarily related to superbugs or viruses, but just health concerns in general. In the United States, we hear a lot today about obesity and diet, and how diet obviously links to obesity. We also hear about smoking and excessive use of alcohol and other things. But in terms of if you look at the United States as a whole, looking across a wide swath of the country, are we better off health-wise today than we were maybe 30 years ago?
We are better off health-wise right now than we were 30 years ago. So we've had pretty dramatic decreases in heart disease. Heart disease is it's the number one killer worldwide. The infectious diseases are important in parts of the world, but things like heart disease are the #1 killers overall. And so we've had a fairly good decline in that. Things like stroke, we've had a decline in. Smoking rates are down in the United States. But we're at a point where we're not sure what's going to happen in the future because of things like obesity. We haven't faced this level of obesity ever before in our history. And so we don't know whether that decline will continue or if we're going to go back up again. And there's some concern that we will become less healthy in the next generation. And so that's a major concern. And the costs associated with these chronic diseases are much higher because they're things that you have to treat over time, whereas some of the ones, if you can prevent a disease, then you're not having to do that sort of treatment. And the cost of these diseases is very high.
One last item. We are down to 30 seconds in this
Okay.
segment as well. Time really flies. Have we become a society that's a little too paranoid about germs because everything is antibacterial these days, the soaps, detergents, and so on? You need some immunity resistance, and in order to develop the resistance, you need some exposure to germs. What about that?
Well, there is now something called the hygiene hypothesis, and that's exactly what you just said, is that if we don't have any exposure, we will be more likely to develop allergies, we'd be more likely to get sick if we're exposed to something because we haven't had any of the challenges that we would normally have. That's an area of research that's, I think, expanding, and it's going to be interesting to see what happens in the next few years in that area.
As one researcher said, get your kids vaccinated, but still let them play in the dirt.
There you
I
go.
guess that's the way to go. Thank you so much, Kevin, for being with us today.
Thank you.
And thank you for joining us on Talking Points. Join us again soon for our next episode. Until then, I'm Dave Kelly. Have a nice day.